Good afternoon, everyone who's just joining us. We'll just wait until everyone is joined, and then we'll take it from there. Just give it maybe a minute or so. As you can see, the numbers are just ticking up at the moment. So I'll just wait just a minute, and then we'll get going. Okay, I think we're still ticking up, but we might be ready to get going. So welcome everyone to this special webinar for National HIV Testing Week. My name is Taku. I'm the head of HIV prevention at Terence Higgins Trust, and also lead the team as well, like on the delivery of HIV Prevention England, the program. And we're really excited to be joined by Laura Hilton and also by Tamara Djuretic, who are going to be talking us through some of the information that about this webinar today. So we would just to let you know, it's going to be recorded as a session so that some other people also can access the information which is going to be shared in the webinar afterwards. So if you've got any questions, there is a Q&A function that you can be checking some of the questions there, or if it's trouble for you, you can check some stuff in the chat bit as well. So so that we can make the best use of the time, we can start Laura, like were you going to start, and then we go to Tamara, or we start with Tamara?
I think Tamara's going to start and I'm going to follow on.
Yeah, well, all right. So yeah, we're going to start with Tamara, and I'll let them introduce themselves so that you don't forget before they start. Okay, brilliant. So Tamara, over to you.
Hi, good afternoon, everyone. Hopefully you can see my slides. Let me just put it on a slideshow. Yeah. So my name is and thank you, Taku, for introduction. And thanks for the invitation. It's great to be here today for the HIV testing week. So my name is Tamara Djuretic. I'm head of HIV section in UK Health Security Agency, and what I'm going to talk through in the next 15 minutes is some data information and epidemiology in terms of the HIV epidemic in this country, and testing, different testing outlets. So particularly testing in sexual health services, community HIV testing survey, which takes data from about 19 community sites across the country, and then ED opt-out testing. So where are we now? We've got about estimated 104,000 people who live with HIV in England. And on this map, you see the red areas around London, Brighton, Manchester are the areas of what we call a very high prevalence area, where we have prevalence of more than 5 per 1,000 population. And we look at not the whole population, but people between 15 and 59 years of age. Then amber areas are areas of high prevalence, and then green areas are areas of low prevalence. So as you can see, most of the country in effect is actually a low prevalence area, but we are seeing more and more infections in those areas too. We have published nationally an HIV action plan from 2022 to 2025. In January, we closed this action plan with a view to prepare a new action plan this year and publish it this year. And we have really great ministerial support for HIV. It seems to be a priority nationally, which is really good news. In the action plan 22 to 25, we have had a target of reducing HIV transmission by 80%, and we look at new diagnoses as proxy for transmissions. But what you can see on this graph, unfortunately, that we have seen an increase in new HIV diagnoses made in this country, which are a proxy measure for transmission. When we then look at the new diagnosis by exposure, what we're seeing is plateauing and slight uptick in 23 in gay, bisexual, and men who have sex with men. But in heterosexual population, we see a much bigger rise. So the epidemic in the last years is actually changing. Over the last 40 years. We have made a really fantastic improvement in reducing incidence and prevalence of HIV in white GBMSM in particular, but for heterosexual population, I think it's the way to go, and we are seeing those inequalities, unfortunately. And on this slide, what you can see on the left-hand side is GBMSM. I'll refer to GBMSM for gay, bisexual, men having sex with men. Going forward, you see this breakdown by ethnicity, and then on the right-hand side, what we see is a big increase in heterosexual population, specifically from Black African population, and then also Black Caribbean as well, but not as high. The good news is we have seen an increase in HIV testing overall, and specifically here, this graph refers to testing in sexual health services between 2019 and 23. We still haven't recovered fully to pre-pandemic levels, but what we also see is this shift in increase in online testing as well. In terms of non-specialist SHS, sexual health services, we do see a small proportion, and that could potentially be due to a lack of data collection, but it could also be due to not being not actually happening in those particular services as much as they used to, as we see more on online testing. We then look at the proportion of positives in GBMSM population and the positivity, and we see a higher increase in outside London rather than London. And very similarly for heterosexual population, we do see this increase, even a decrease, if you like, in London, but increase outside London. And this is another slide to show further inequalities. I guess this is the HIV testing offer and uptake. So the blue squares are a proportion of people who have declined the test versus those who were tested in green. And you see the biggest decline is in women in particular of ethnic Black African, but also ethnicities other than Black African. We are looking into the reasons why. Some of the things could be the way that sexual health services work, whereas in specialist sexual health services, we are much more likely to see GBMSM population. But partly is also anecdotal evidence suggests it's stigma amongst frontline staff, health and care workers, who potentially don't engage in a way that they could have, I guess, in services. We then looked at the community surveys. So what this is asks everyone across the country who have testing in a community. That could be anything from nightclubs, volunteering community sector outlets. It does not include primary care, does not include prisons. So it's mostly community testing, including those during the HIV testing week, but not all of those happening during the HIV testing week, if you like. We had 19 services reporting to us, and we have seen almost 20,000 tests being carried out in 23, and had 55 reactive tests. So the number of tests have increased since 2022, which is really good news. And let's see what's going to happen this year. We're hoping for even a further increase. But what this survey captures is only a proportion of those tests that took place during HIV testing week. So it excludes all online testing. And what you see here is what type of tests have been taken with a point of care test, the highest. And when we then look at the exposure, it's quite similar, a proportion of GBMSM versus heterosexual, a little bit even more heterosexual, which is good in a way that it's slightly different to what we see in sexual health services. And then when you look at the ethnicity, over 60% is by ethnicity, but we are seeing, compared to others, which is not on this slide, compared to other years, we are seeing an increase in testing in ethnic minorities. And then when we look at the reactive tests, this doesn't mean that all of these reactive are not positive. It means that we have not got the data. We haven't been given the data. So if you are out there, one of those who do submit this data to us, please make sure if you do have results on the true positive to put it forward. But what we have had information for is about 40% of all who were true positive. So you can see about 22 were true positive, and of those 15% were new diagnosis. So so it is another way, I guess, of getting people tested and positive. So we're moving on to the ED opt-out BBV testing service. So what that is in a first wave, we selected emergency departments in areas of a very high prevalence. That's Manchester, Brighton, London mostly, and that program has run since April 2022. And what UK Health Security Agency have been commissioned to do the evaluation of this program, that all the tests, or everyone who comes in and who has indication of taking a blood test is tested for HIV, hepatitis C, and hepatitis B. And you can see on these slides almost 2 million of HIV tests, a little bit less for hepatitis C and for hepatitis B. But what's really staggering is that for HIV, for example, 73% of people tested in emergency departments have not had a previous HIV test. So we're finding people who have not either accessed sexual health services or any other traditional services such as primary care, for example. We have looked at the period of 24 months, and this is for all 34 sites in very high prevalent areas. I guess when we then looked at the number of positives, we had to zoom into 21 sites for which we did have information. So it's not the whole picture, but it's quite a big proportion. And what we see there is that during that period, we had 391 new diagnoses of HIV between April 22 and March 24. In addition to that, which is also really important, we have found 314 people who were previously diagnosed but not in care. So this program not only finds new positives, but it's also help us to link people back to care if they were lost for treatment. And certainly, as you can see on the slide, we've got many more new diagnoses in hepatitis B, which is almost 2,000, and hepatitis C. When we then looked at who comes to ED departments and get tested positive, which is a blue line, versus these gray lines are everyone else who get tested in sexual health services, primary care, and so on and so forth, acute care as well. And we looked at their demographics. So what you see for HIV in particular, you see that people tested in ED departments are much more likely to be older. So you can see here people over 35 years of age in particular. They're more likely to be women and people from Black ethnicity as well. And what's interesting in terms of the prevention is for hepatitis B and hepatitis C, we see in ED departments people from more deprived areas, but for HIV, there is a slightly inversion, and we see people from actually less deprived areas. The only other thing people keep asking, so I thought I'll put it here. What's the impact of ED testing on increase of new diagnosis? And what we can see in London, that's definitely there is an impact, because if we took out all the ED diagnosis, which is a green line, you would actually see a decline in new diagnosis in London. But outside London, ED does not have as huge impact in terms of increase in new diagnosis. So it's very likely that I guess ongoing transmission is taking place outside London. So in conclusion, just to say that HIV testing is crucial for prevention, access to pre-exposure prophylaxis and treatment, certainly. And it's good to see that HIV testing has increased over the years, but we are seeing inequalities in who is accessing and who is accepting testing. And I think thoughts and thinking is divided out there about online testing. We have seen a big shift in online testing. I guess what is really important to acknowledge is that one size does not fit all. So having a different outlets for testing, it would be community testing, be it sexual health services in the departments or online, is really important for different population groups to have that access as they see it fit best for them. It looks like the targeted community testing appears to be successful, and then I guess what we do need to do, and we are committed to do going forward, is to understand barriers to access much better than we had so far. There are lots of small studies, I guess, across the country. So gathering all that feedback and making sure we use that to change the services, if you like, or tweak the services would be really good. And unfortunately, we know we have not met HIV action plan target by which was 80% reduction by 2025 since 2019. And in terms of the zero transmission by 2030, we are meeting it overall, but for specific groups, we are not there yet. We're quite a way away. So some of the things that we are thinking of putting in the HIV action plan, it would be useful to get your views, because these are early early thinking. Is this is specific to testing. I haven't put on this slide everything. We have a really good BIVA adults HIV testing guidelines. They're based on the evidence. They talk about opt-out testing in sexual health services, in more testing in primary care. Does not happen consistently across the country. And what's good about opt-out testing, as we can see in ED department, is it takes out clinical decision of who clinicians think should have a test, but it also takes out stigma potential and discrimination perception and biases and discrimination as well. So if we could work together with services to fully implement opt-out testing in sexual health services, that'd be great. We also did a small study talking to people about what stops them testing, and it's definitely about awareness raising, for which this week is absolutely fantastic. Of all HIV prevention interventions, lots of people don't know that PrEP exists and it's for free. So the more we could do on that education and awareness raising, the better it would be. We also do think that we are doing a full evaluation of ED testing in very high and then high prevalence area as it's been expanded this year. And we will have some evaluation coming this autumn and then next year. But pending those findings, we think continuation of ED testing would be a really good thing. And then thinking about scaling up community testing with a particularly targeted approach for those groups that are more likely to benefit from it, such heterosexual population and people from ethnic minority groups. I talked about understanding reason behind decline for HIV testing in women, but in men in particular as well, from Black African, Black Caribbean communities. We are doing okay for partner notifications, but not recovered to pre-pandemic levels. So it would be useful to do a little bit more on partner notification. And then late diagnosis, it's about 40% of all diagnoses are still late. We are doing much better than the other European countries, but it's really important that we do understand the reasons behind late diagnosis to focus on testing interventions. So I'll stop there. Thank you very much.
Thank you so much, Tamara. Thank you so much, everyone who's putting the questions. We'll do the questions at the end so that Laura's time, we don't end up sort of queuing into Laura's time. So in the interest of time, we'll move on straight to you, Laura, and over to you.
Thank you. I'm just going to see if I can share my screen. Bear with me. Can you see that, Taki?
Yep, that's come through.
Lovely.
Just if you can just put them on slide mode at the moment, they're still, yeah.
Oh, I'll have. Is that working?
No, I think probably it's doing it on your other screen or something. Yeah.
Yeah, sorry. In the NHS, some trusts, such as mine, we don't use Zoom. So we have to access it in browser. Thomas has got my slides, so he can share them if I stop sharing. And I'll just talk to you.
Yeah, Thomas.
So I'm Laura Hilton. I'm HIV nurse consultant for Mid and South Essex. We are a high prevalence area and we are hoping to go, thank you, we are hoping to go live with ED opt-out testing in all 3 sites next month. So exciting but busy times. We also have a high migrant population here. So that's why I've been asked to speak today. So I'm going to speak about 2 things. First of all, I'm going to speak about some data I collected nationally a year and a half ago now, and then I'm going to talk about our experience in Mid and South Essex and how things are changing. Thank you. Next slide. So in terms of the national picture, in 2023, various sites were starting to report that we were seeing a higher migrant population coming over from various countries than we had for a while. So 8 centres in the UK agreed to give data to us. So basically myself and some other nurses went out to NIVNA and talked at NIVNA conference and asked if any centres would be able to share data, and we sent them 2 questionnaires, one to look at service level data and one to look at 20 completely anonymised patient records to look at what was happening, what the picture was. So we managed to collect data from 8 centres in the UK, and we analysed data from 155 people. We excluded 8 for not meeting our criteria. For example, they were actually new diagnoses, not transfers from overseas. So the clinics that agreed to share data, 6 were hospital-based, 1 was sexual health-based and 1 was not known because they didn't give us that data. And we had a real mixture of urban, rural and in between. And we had small through to large cohorts. So the smallest cohort in Cornwall was 300. And then we had Bart's Trust, who had a much bigger cohort. We had varying skill mixes and prescribers within the teams. And there was a range between these 8 services of 9 to 39 new transfers from abroad in a 9-month period from January to September 2023, which is when we retrospectively collected data for. So one clinic, Somerset, who were a small clinic, had reported an over 10% increase in their cohort, and most had about a 3 to 4% increase in that 9-month period. Next slide, please. So this were the 155 patients. So the majority were women, 60%. We had 39 men and we had 1 patient who identified as trans. The age range, as you would expect, was mainly people that were of working age. So we didn't see very many very young and very old, but most people were in those age brackets from 20 through to 60 and had come across to work. Next slide, please. In terms of the continent of origin, 80% of the patients from those cohorts were from Africa, and then we had a mixture from across the other continents. In terms of the African breakdown, 56% of the people transferring were from Zimbabwe. We also had a fairly big cohort from South Africa and Nigeria, and then it was split across some of the other countries. Next slide. So the reason for immigration, so 72% of people had come across for work on skilled person visas in the whole. Some had come to study, a very small 5% were here to seek asylum. Some people's spouses had come across to work and they were here on spousal visas. One person had come across on a 6-month visit to visit family, and then the other 6% had varying reasons for coming across. In terms of what people were over here to work as, 37% of people were here as carers. And I would say that about 80% of people we see are here as carers. Other people had come into healthcare. Some people hadn't specified, unfortunately, so we didn't have the data. And we also had a small proportion of teachers, engineers, social workers, etc. Next slide, please. So when people made contact with us, some of them had been here from 3 days, but there was a few people that had been here for years, and they'd either had a really big supply of medication from their home country or they'd been eking out their medication. So we did have one person that had actually been here 4 years before they made contact. But the mean value was 116 days, or if you looked at a different way of analysing data, it was 189 days. So most people had been here 4 to 6 months when they made contact with their new clinic. They primarily self-referred, half of them, but there was also people that had gone around the houses trying to find out how to refer themselves, and had either come via GP or sexual health, inpatients, voluntary section, family members. Some of our poor patients had actually gone to the GP to ask how to be referred. They'd sent them to sexual health, and then they finally got to us. And for these people, it was difficult because often they'd run out of medication or were about to run out of medication when they finally made contact with the right clinic. Next slide, please. So what were they entering the UK with? So most people were coming across on dolutegravir-based regimes, 76%. For the vast majority of these were 3 and 1 combinations, such as Acritega or Tenalan-D. A small amount, 12%, came across still on efavirenz-based medication. We had 2% on Biktarvy, a small percentage of 3% on protease inhibitors. 5% of people had completely run out of medication, so they entered with no medication, and then we had a couple that were just on Adefsy and raltegravir. So when they entered the UK, patients had between 0 to 300 doses of antiretrovirals actually left when they entered. Nearly 20% had no medication left at all when entering the UK or making contact, which is really concerning for them. Some had run out sometime before. May have meant to be in multiple meetings. Some had run out sometime before or had been stretching their doses, so taking doses every other day, which obviously has resistance ramifications for the patients. A third of patients had 2 weeks or less when making contact. Next slide. So in terms of what they were switched to in the UK, 2/3 were kept on a dolutegravir containing regimen, although for most people that meant taking an extra pill, taking 2 pills when they first entered. 13% were switched to Biktarvy to try and make it easier for them, and 1 patient was later switched to injectables. Small proportion were given NNRTI-based regimes, but some of these had come to the UK on integrase-containing regimes. So the issue for some, and I'm going to touch on this in a moment, is that we didn't have very much data about what medication they'd been on before. So sometimes switching to an NNRTI is switching at risk. Like I said, most overseas transfers came across on a 3 and 1 combination of dolutegravir, emtricitabine and tenofovir, and they were given in the same in the UK in 2 pills. An incomplete antiretroviral and resistance history may make it more difficult to give them more options for the future. Next slide. So in terms of whether there was transfer history available at all, for over 2/3, 68%, there was absolutely nothing. They didn't really know what they'd been on, and there was nothing written to give us. 13% did have a complete written history available, and some people were able to give some verbal information or very scanty written, but it was difficult with most people to get a real feel for what their viral load and CD4, for example, were at diagnosis and what their health had looked like. In terms of language barrier, nearly everybody spoke English to a really high level, so nearly 90%, but 11% did have some language barrier, particularly from some of the Asian countries and some of the Eastern European countries. Sorry. Next slide. This was primarily a well cohort of people. Most people had a CD4 count above 500 when we first saw them. A small proportion had low CD4s, but it was a small proportion, with only just below 20% having CD4s below 350. Most people were well controlled despite the issues with eking out medication. So 78% of people were undetectable when they were first seen in clinic. And the majority of the rest had low-level viremia, with a worrying 7% that had a viral load of between 10 and 100,000, and 3% had over 100,000, so high viral load. Next slide, please. So most, 3/4, had no co-infections or other significant morbidity. However, 13 people had TB, with 11 of these having active disease and 2 cases of MDR TB as well. We didn't look at latent TB, but most places are testing for latent TB. 9 patients had syphilis at initial testing and needed treatment. 7 were hepatitis B positive and 4 had active hepatitis C. Some people did have chronic issues such as hypertension or type 2 diabetes, but 1 patient unfortunately was diagnosed with cervical cancer as they arrived, and 4 were referred from acute services as they were unwell. So there was a small proportion that were very unwell when they were first seen, and 1 couple's child was diagnosed HIV positive in the UK and linked to care. Next slide, please. So in terms of tests, there seems to be a bit of a national discrepancy going on about what is being done. So most people had an HLA-B 5701 test to see if they would react to abacavir. Some centres are routinely doing resistance testing at baseline, even on those that haven't had treatment interruption and are undetectable. So that doesn't really have a clinical implication, but it does mean that those trusts are spending money that perhaps they don't need to. Of all the patients we've seen here in our centre, we've ended up bringing 2 back only because they had detectable viral load to resistance test them, and 1 had significant resistance. So I would suggest that maybe we don't need to routinely resistance test unless people have high viral loads. Not all people seem to be having T-spot or TB testing done at baseline, but as most are from high prevalence areas, this should be done routinely unless we have a definite history of TB treatment or prevention in the past. Next slide. So in terms of what we are seeing, so we are 3 relatively small services with about 1,500 in our cohort, and most of our clinics are nurse-led. So in 2023, we saw a big increase in our new transfers, and mostly they were coming from Southern Africa. Nearly all were care workers, and most were living in shared accommodations, and the shared accommodation was very difficult. We visited a few patients at home because they were unwell, and they had things like no bedding and just plastic on their mattresses, and they didn't know the people they were living with, so keeping information safe was really important to them. We've seen a few healthcare workers and some who have been newly diagnosed on entry to UK by occupational health or the GP. In total, we have seen 59 transfers from abroad and 48 from Africa in 2023. And then in 2024, we continued to see a significant number of new migrant transfers. So we saw 54 overseas transfers, and again, the majority were from Southern Africa, and that was data up to the end of the year. In 2025, we're seeing overseas transfers coming in from abroad, but we're also starting to see people migrating around the UK for work purposes to try and get better working conditions. and therefore transferring care within the UK. Some people that have only been in the UK a year or two have transferred 3 times because they're trying to improve their life. So people are telling us that it's really difficult to come to clinic. They're often being given last minute rotas, being told they're not allowed time off, that if they don't work all the hours they're told they need to work, that they will be given 0 hours next week. And obviously people can't afford to live on no money. So they're often expected to work 60 hours plus per week with very little ability to say no. And therefore some people are finding it really difficult to prioritise their health. And as I said, most of our patients are also coming with very limited transfer history, so we often don't know their resistance history. However, what we do know is, for example, in Zimbabwe, where most of our patients come from, that they used efavirenz-based regimes early on, and then that changed to dolutegravir-based regimes, and we can usually get from the patient whether they were changed because the regime changed across the nation, or whether they were changed because they failed. So we can usually make fairly good decisions by speaking to the patient. Next slide, please. So, as I've said, patients are often moving around the UK doing live-in work, which presents challenges for continuity of care. We're trying to offer virtual consultations to make it easier, and home care delivery, so that if people are moving around to different parts of the UK, they can remain under our care, with every other consultation being virtual and having to have full bloods done yearly face-to-face. But we do like to try and see them face-to-face for their first 2 visits. So for the first year, just to make sure that we have done everything we need to do, sorted out any latent TB, etc., any sexual health issues before they are then not seen face-to-face all the time. We are also seeing children and adolescents who have newly migrated. So we've had 3 children in the last 2 years from Zimbabwe that are being seen in our paediatric clinic, but also linked into Great Ormond Street. Patients often have limited family support around them. Many have children back home, so it's difficult. We've seen 9 pregnant ladies across the 3 sites who have newly migrated, and it's often very complicated. So they may have incomplete history. A lot of them culturally prefer to breastfeed, which we do try very hard to support. Not everyone had disclosed to their partner, so we've worked with them to disclose. And often the way things are done back home is different to how we do things in the UK, so we need to make sure we know the status of their existing children back home. We also had an immigration centre near Chelmsford opened in July 2023, and we expect lots of referrals because they're testing all new entrants, but actually the Chelmsford team have only had 2 new referrals. Next slide, please. So we're also seeing a small proportion of new diagnoses of HIV in this cohort, and they're often very late diagnosis and they require hospital admission, and some of them have been transferred to Barts and the London and needed ITU admission. And this makes them working and fulfilling visa obligations very difficult. So, for example, there was a lady that came across with her husband from Nigeria. He got sick and died quite quickly, and then she was diagnosed with PML, so she now walks with a walker and life is more difficult, and she's not been able to work since she got there. She's linked in with the right agencies to try and help her with that, but it's been difficult. Sometimes there have been times that we have struggled to cope with demand, such as when we get 2 or 3 new referrals a day, and often people have got 1 or 2 tablet doses left, so we've had to be quite creative in how we make that work. We may just take some data from them, give them a month's supply of tablets, and then see them a couple of weeks later to do a full consultation. Next slide, please. So in terms of conclusions, there does appear to be a nationwide increase in people transferring from overseas with known HIV, and it appears to have started late 22 to early 23. A significant proportion appear to have been recruited for healthcare or care work. Interestingly, I read the Code of Practice for International Recruitment of Health and Social Care Personnel in England, which is up to date. It was updated at the end of last year. And it says that various Southern African countries are on the red and amber list where they're not economically or financially stable, so they shouldn't be having healthcare and care staff recruited. So I don't know how the agencies are getting around that. Also, anecdotally, we know some people are being promised care work but not being given working hours once they're here, or they're being expected to work a lot of hours, too many hours, and given their rotas last minute, which is very difficult for them. Bear with me, my computer's trying to sign me out. Next slide, please. So it's unclear yet as to whether this cohort of people will choose to remain in the UK long term, bearing in mind that life is difficult for a lot of them, or whether they may choose to return to their country of origin. Many people appear to not know how to access healthcare on arrival or their rights to healthcare. And a lot of people are hiding medication and not bringing information because they're worried that they'll be chucked out of the country if people know they're living with HIV. So there is some national work going on. THT and various other national agencies are involved. And we're looking at whether we could get a leaflet out to all agencies and all places where people may enter the UK, looking at living with all chronic health conditions, not just HIV, and how you access care for different chronic health conditions when you get to the UK. So this is being worked on by third sector, NAT in particular, I believe. So some trusts and clinics are struggling to meet the increased demand, and there needs to be recognition of this and the need for increased resources in some areas. And again, this is being looked at nationally. Next slide, please. And these are the clinics that help to submit data for those 8 sites. So thank you very much to all of these clinics. Thank you. Next slide. I think I'm finished. Thank you.
A massive thank you, Laura. And I hope that also brought sort of a different dimension in terms of looking at sort of the challenges that we're facing. I would like to invite Tamara to come back on camera if possible, so that we can then sort of address some of the questions which have been raised by people. Thank you very much, both. I think it's quite important that we always try to tell the story of the numbers, the story of actually the substance as well, of the experiences of what's happening in terms of people's lives. So maybe I'll just go through some of these questions and I'll put them to both of you, and whoever feels they are best placed to answer that one, we can do. This first one actually probably is for you, Tamara, which is from Catherine, which is, given the aging profile of people living with HIV in the UK, are there any future plans to consider extending the later age for prevalence data, that is like sort of moving beyond 59?
Thank you, Taco, and that's a very good question. I guess the definition comes from UNAIDS, and their current definition is 15 to 49. So in the UK, they have lifted it up to 59. But you're absolutely right. As people are starting to age, it is good to reconsider. So I'll take that back, I think. And at the moment, I'm not aware of any discussions about that. But I do think in the next 5-10 years, and to link with the HIV New Action Plan, would be useful to think through that.
And then the next one, I think, probably is linked to when you were presenting as well about the people who are declining tests in sexual health services. Whether there is any information on needle phobia. Is it has there been any work done to look at needle phobia amongst those people who decline an HIV test?
So thank you. We don't have necessarily a data on why the reasons for decline are, and there could be different reasons. It could be certainly needle phobia, but it could also be something to do with data. Sometimes women who come in for reproductive health don't always get offered it, but it can be recorded as decline. So we're really looking into it. But what I am aware is that there's been some discussion, specifically on antenatal testing. Needle phobia comes up quite a lot. Antenatal testing is very much opt-out testing as well, and it's always been very, very successful, over 95 uptake. But for that small proportion who decline, some of the reasons are needle phobia. So there have been some sort of not studies, but looking at interventions, how to overcome this. But what I just came off from the meeting where we discussed that, and it's not necessarily a very easy one to do. I wonder whether Laura, in her practice, has any I don't know, tips on that.
Well, we have an interesting patient actually who's very needle phobic and has been very clear that he will never ever have bloods done. So he was a partner notification because we were looking after his partner who was pregnant, and because it was a domestic violent situation, we asked sexual health to contact him. They did a point of care test. He fainted. He then walked out before he got his result. He then eventually got tested, got his result. We've never been able to do confirmation because he has told us he will never have needles, and we're treating him with a combination of drugs that we think are likely to be robust and will treat hepatitis B, just in case. But because his partner's positive, we knew he was likely to be positive. It's a very difficult one. It is very difficult, and a lot of people are needle phobic.
I guess that is something as well for us to discuss, like sort of as a sector, sort of going forward as well, in terms of the different ways that we can also make it easier for people to test. I know, for example, in terms of the offer, in most cases of the online testing that we've seen, it's all mostly blood-based. I know that there's a bit of people who use like OraQuick, but it's mostly blood-based. I know from a THT point of view, we do offer OraQuick as well. There are people who use the OraQuick one on the basis that they would not have done it if the only option was blood, which is quite an interesting one as well to look at. Yeah. So next question is from Nyambe. So are they like this one is to do with understanding sort of the variations of what's happening in different parts of the country. So are there as yet any supposition that may link lesser resources or funding for HIV prevention work in particular populations to why there have been increases in heterosexual HIV transmissions?
Yeah, we're not really sure why. Laura Walters, that leads the CRG, is aware of the issue and is sitting on a national panel with myself and various other people. And we're looking at whether, how can we reallocate resources in this time of austerity and when trusts are all in triple lockdown, etc. Financially, it's very difficult, but there is an awareness, but what we're not sure is why. And people seem to be coming to the slightly smaller centres on the whole, maybe because that's where more care agencies are recruiting, maybe less care agencies are recruiting in London. I'm not sure.
Tamara?
Yeah, the only other thing, and that comes from actually THT discussion, is it's very hard to say that that's the reason why. There could be multiple reasons. I think one of the reasons is as we are getting closer to zero, so as we are seeing less people with new diagnoses, you see this change, because if you like, the white GBMSM population that has been a focus of for the previous years, it was in a way masking what we're seeing now, if you see what I mean. So that could be one of the reasons. The other reason in discussion with THT is that some specific ethnic groups really engage better in proper outreach services, which we do know that there are less and less of them due to funding. So if you look at online services, for example, there's been a recent evaluation of online services, and you would see more white ethnic white people and GBMSM, white GBMSM in particular, testing than heterosexual population from ethnic minorities. So I guess focusing or maybe redirecting resources on outreach services for testing in those communities would be really useful if possible. But whether the actual funding decrease has resulted in that, it's very hard to say. No studies to prove it, though.
Well, like we will continue working with you, Tamara, and your team for you to give us the data so that we understand exactly where we need to put our resources, like to make sure that we do get. I think the message really is it can't be just normal as before. Like in terms of responding, going into the future, we would need to be looking at things maybe slightly different. And then Catherine also had another question, which was if it is clear that professionals in healthcare, in sexual health services, are not offering HIV tests evenly to everyone who comes through their service, what work is happening to build their skills, capacities, to change their current practice? Could certain clinics be targeted with UKHSA and BIVA support, where it's clear that not everyone in that clinic is receiving an offer of a test? So this is the issue again about people, the research that you're talking about, Tamara, about people not being offered a test. So what can be done for that? That's, I think, the question.
Thanks for that. Again, it is one of the things that we have been looking into. and the reasons why. We haven't done a research, but we have spoken to different clinics and got some anecdotal evidence. So it ranges. It ranges from sort of stigma and perception that, let's say, if someone comes in, is not at risk of HIV and therefore it's not offered a test, which is a presumption without actually engaging in that sort of conversation. And sometimes these could be some difficult conversation as well. So that could be one of the reasons. The other one, clinicians say it's lack of time, money, and resources, because what you need is so when you come in, so some of the screens, well, most of the STI screens are swabs. They're not blood tests, apart from syphilis. When we look at the data, those who are tested for syphilis do get tested for HIV most often, but not for other STIs. So it would need time to draw blood, basically, which happens in sexual health clinics by clinicians themselves. There's no kind of referral route. So is thinking about, and some clinics do it, and some clinics say they don't have time. So thinking through that would be really useful. And the third thing is about education, in terms of stigma education and awareness training. And we are trying to roll out HIV Confident. Some of you might have heard about this, which is a package of training that is led by NAT. But there are other trainings in terms of reducing HIV stigma. It just happens very sporadically. It doesn't happen at scale. So it needs a little bit of funding, and it's little bit of jolling people along to do it, I guess. But it is going to be in our HIV action plan for the next 5 years.
Brilliant. So, because I'm conscious of time, Laura, there's a point of action. You need to get in touch with Kirsty, with Kirsty Foster, so that you can link about the survey. I know that I've actually, every time you've spoken somewhere, there's always somebody who's planning to do a similar survey, and it would be good for you to link up on that. And then so
I think so, yeah, so I was just going to say, Taco, I'm reading chat. I'm happy to share my slides.
Yeah.
I don't know if Laura is, but yeah, we can send them around.
Brilliant. I know that there's more that people would like to ask. The one thing that I just want to to say is, I think like you've already said, we will be sharing the slides. There will be a recording of this conversation as well, which will be available after this session. So what we can do is also look at the last thing from Catherine there. So Catherine, so there's a lot of chats. I'll be in touch actually about your last question, about some of the work that we're also doing with UKHSA, with Laura, in terms of what could be done about where the information goes, and attempts to work with some of the recruiting agencies, for example, to try to make sure that they provide the information. It's quite tricky because some of them, they would rather not talk to us because the individuals that they're recruiting are complaining about them. And most of so it's been quite a tricky relationship trying to work with some of the recruiters, because they would rather not talk to us, because the way that they're treating some of the people that they're recruiting is absolutely atrocious. So they try to stay out of the public light, more or less. So definitely, but we have something to talk about that. I just want to say there's more stuff which we could talk about, but our time is a bit limited. I just want to say massive thank you to Laura and to Tamara for sharing your time today. It's still National HIV Testing Week at the moment. It's still going on, and we've already had over 13,000 tests have been ordered for Testing Week already, and I think we've still got about 9,000 more to go. So lots of work to do. But please, let's continue the conversation. This is not the only opportunity for us to continue talking about this. I would like to encourage everyone who does community testing that when the call out comes out this time as well from Tamara's team, for us to complete as much as we can so that we actually give a better picture of what is going on in terms of community testing. I think the story, like was already said by Tamara, there's no one size fits all, and so we need to be able to demonstrate what is happening in community testing so that the evidence is considered. Otherwise, if an incomplete story is told, the evidence might not be favorable. So it's best we try to give a fuller picture as possible. Laura, Tamara, everyone, thank you very much for coming, and we will see you all very soon at some other event. Thank you very much, everyone.
Thank you.
Thank you. Thanks, Zach.